Good morning, everyone. An update on tocolitic drugs and corticosteroids, which is not so exciting in exciting days. Because finally there is some progress regarding preterm labor. The old we had for 30-40 years, corticosteroids, antibiotic, tocolytic drugs, these are classed. Now we have extras. We know about the importance of the short cervix, there is the progesterone, there is the pessary, there is magnesium sulfate, and that all happened in a period of time of 5-6 years. And before that time, nothing at all. And here's some of the data of our chairman. Vaginal progesterone in women with short cervix, yes, it helps. The Arab pessary, yes, the data from Barcelona are very good. The conflict with Kypros, I don't know if it has been solved because he didn't find it to help. And here we have the data on magnesium sulfate and cerebral palsy. And you can also see that the evidence that there is that it helps in reducing the incidence of cerebral palsy. So marvelous. And here I am talking about the old tocolytic drugs in corticosteroids. This is a recent review in the Lancet. The use of corticosteroids and tocolytic drugs in 29 low, middle-income countries. How often are they being used? And one can see the tocolytic drugs were only used in 20% of patients delivering preterm, and corticosteroids in 50%. That's not a lot. Is that wrong? Well, as far as tocolytic drugs are concerned, I'm happy with it. Because there is not a lot of evidence that it will help. With steroids, there is a lot of evidence that it helps. At the same time, those drugs are also very dangerous, and that will be my presentation. First, let's move to the tocolytic drugs. Usually it is in medicine, the more efficient the drug is, also the greater the side effects. And we can see that the best drug we have to stop contraction is indomethacin, but it has many, mainly fatal side effects. If you look at the other drugs that do seem to work, beta agonists, calcium channel blockers, oxytocin antagonists, side effects are highest in the agonist, lower in calcium channel blockers, and by far lowest in oxytocin antagonists, whereas the positive effects seem to be more or less the same, and that's the reason why the Royal College in the UK now says first choice should be either be calcium channel blockers or oxytocin antagonists, and magnesium sulfate and nitric oxide donors are not very effective. Well, so if positive effects, tocolytic effects are more or less the same, it becomes very important what are the side effects, because then you should give drugs with the lowest side effects. And this is a study that we conducted in the Netherlands and in the north of Belgium, a prospective observational study on side effect of tocolytic drugs. And one can see that with nifedipine, 500 cases altogether, severe maternal side effects in 1%, mild side effects in 1.5%, so altogether 2.5%. Beta agonist, 2% severe, 2.5 mild, 4.5. And here is the atosiban, no severe side effects, and only one case of mild effect. These were all single courses. If you look at sequential courses, lower number, it was more or less the same. But if you look at combined courses, and that's still common in some places where they use two drugs at the same time, you can say that there is the highest incidence of severe side effects. And if I talk about severe side effects, it's dyspnea, hypotension, lung edema, hypoxia, cardiac failure. The distribution, and this was about the year of 2008 in the northern countries in Europe, atosiban was 40%, nifedipine 40%, and beta agonist in 10%. So that was the distribution of use. But if you look at the different maternal condition, there was the same distribution. For instance, in women with preterm labor who had diabetes, you can say 50%, 30%, 16% of use of beta agonist. Which in a way doesn't seem to be wise, because we know that side effects of beta agonists in diabetes are dominant, and they may cause severe ketoacidosis in these women since they change the new glycogenesis in the liver. So it's stupid. Look here at pre-existing cardiovascular disease. Probably better not to use nifedipine, and here you can see the distribution is exactly the same. So apparently in the Netherlands and Flanders, the underlying maternal condition is not taken into account when deciding which tocolytic drug to use, and that doesn't seem wise to me. Altogether, do not use beta agonists anymore. Do not give combined courses, because there's no evidence that it works better than a single course. Consider giving atosiban, especially in cases of multiple gestation, diabetes, and maternal cardiovascular problem. In other words, take the maternal condition into account when deciding which drug to use. And maybe we should also reassess the role of prostaglandin inhibitors, but not in monocovalent twins. This is a recent study from the Netherlands, presented at the Society of Maternal Fetal Medicine months ago. A randomized controlled trial comparing nifedipine with atosiban, 500 cases altogether. There was no significant difference in the duration or prolongation of pregnancy, although it was on average 2 days longer than nifedipine. There was no difference in the overall incidence of adverse perinatal outcome. However, perinatal death was significantly higher in the nifedipine group as compared to the atosiban group. And I think the absolute values were 18 and 8 or 9 or something like that. This is now being under investigation, which were the backgrounds for perinatal or for fetal mortality in these cases. But if you look at the old case reports with side effects of calcium channel blockers, here are a lot of maternal side effects, especially women with multiple gestation, etc. But there are brief ones also here. Maternal hypotension, intrauterine fetal death, hypotension, emergency cesarean section, etc. So these might be another reason for not choosing to use nifedipine as a tocolytic. But should preterm labor be stopped at all? If you look at the data, meta-analysis on tocolytic drugs, yes, they seem to work. A birth delay for more than 48 hours in the placebo group 50%, in tocolytic groups on average about 80%. A birth delay for more than 7 days, 40% as compared to 70 days, 70%. So it seems to work, however, with no lengthening of gestation beyond 1 week. And no significant difference in RDS or neonatal survival in studies in which corticosteroids were given in both arms. So they seem to stop contractions, but not to improve outcome. And that's why this was stated in the Royal College Green Top Guideline. No tocolytic drug has been associated with a reduction in prenatal and neonatal morbidity. And what could be the reason for the absence of beneficial effects? Well, we know, especially because of the work of our chairman, that the majority of preterm labors, with or without intact membranes, is associated with infection or inflammation. And both are related to neurological and respiratory problems, including periventricular leukomalacia and cerebral palsy. So delaying delivery may not prevent neurological damage, but may even make it worse. In a way, look also at the Oracle data, antibiotics in case of preterm labor with intact membranes, and there is an increase in incidence of cerebral palsy at the age of 7. So, why don't we only give a course of corticosteroids and wait and see? Or corticosteroids and magnesium sulfate. The more so, since magnesium sulfate seems also to work if given at least 2 hours before the baby is effectively born. Anyhow, if you use tocolytic drugs, 2 days should be more than enough. also for the achievement of proper action on corticosteroids, and for in utero transfer to a level 3 hospital. And what about maintenance tocolitic therapy? So patients have been admitted in the hospital and sent home with maintenance therapy. Well, there have been quite a few trials, only one on an oxytocin antagonist, many on oral beta-mimetics, and until 2012, only one on calcium channel blockers. But it appeared not to have any effect on the incidence of preterm birth, nor on neonatal morbidity. And here is a recent study from the Netherlands, nifedipine maintenance, randomized controlled trial, 400 cases, no difference in outcome, even though the adverse outcome was somewhat but not significantly higher than the nifedipine. Conclusion, no, there is no reason why to use tocolitic maintenance therapy. So who's still using it? The problem is that patients want to be treated and that doctors want to treat. And you're a good doctor if after a spell of preterm contractions and patient has been in the hospital and sent home, if you give maintenance therapy, look, this doctor is looking after me. In contrast to the other doctor that didn't give anything at all. Patients want to be treated, doctors want to treat, but doctors should know better. Conclusions, there is no convincing evidence that tocolitic drugs improve outcomes. If you want to treat, do it only for a short time. And with a drug that is safe for the mother. But you may also consider to give corticosteroids and magnesium sulfate instead. There is no place for tocolitic maintenance therapy, and maybe we should restrict the use of tocolitic for cases with a cervical length of more than 1 centimeter, since our chairman has found that if you look at asymptomatic patients with a very short cervix, the ones with signs of intraamniotic infection had a very short cervix, on average 1.5 millimeters as compared to 11 millimeters in those without intraamniotic infection. And that was also the reason why in their huge randomized controlled trial on the effect of vaginal progesterone and women with a short cervical length, they excluded women with a very poor prognosis with a cervical length below 10 millimeters. Antenatal corticosteroids. Poison with some positive side effects. Am I too negative? I don't think so. Please look at the Lancet of February 14 this year. Antenatal corticosteroids in low to middle income countries. Argentina, Guatemala, India, Kenya, Pakistan and Zambia. The use of corticosteroids was very low in these countries. So they started an implementation program to use it in case of certain preterm births, and they compared it to standard care in a large population, altogether of 100,000 women pregnancy. And the definition of a baby born preterm was a little bit difficult in that population, so they used a proxy for preterm births, a birth weight below the 5th centile of all births in those countries, which on average is a weight in between 2,000 and 2,500 grams. On average, delivery before 36, 37 weeks of gestation. And it ended up that with the intervention, in the intervention group, 45% of women who gave birth to an infant with a weight, let's say below 2.5 kilograms, got corticosteroids, and in the control group, only 10%. My question, what will be neonatal outcome in the infants weighing less than the 5th centile? Did corticosteroids improve outcome? Second question is, what will be the overall perinatal mortality? Did it improve? Third question, what about maternal morbidity? Did they decreased in the corticosteroid group or maybe increased? Well, the first answer is that neonatal morbidity in infants born with a weight below the 5th centile was somewhat lower in the corticosteroid. but it was only given in about 50% of cases with a weight below that. Not significant at all. More important is that overall mortality was significantly higher in the corticosteroid group. A relative risk of 1.12, and look at the confidence intervals. And finally, maternal infections were more common in the corticosteroids group, relative risk 1.4. So overall, in these low to middle income countries, with the use of corticosteroids, there was an impaired outcome. Please read this paper. It is extremely important. Why? Because at the end, 87% of corticosteroids were given to infants weighing more than 2 kilograms, where there is no evidence of its usefulness, but with risks of side effects such as reduced fetal placental growth, apoptosis in the brain, cerebral palsy, maternal infection, which all may explain the overall poorer outcome. These data stress the importance of adequate dating of the pregnancies, which seem to be a problem in those countries, and in identifying women at real risk of preterm birth. Corticosteroids work, but you have to give them to the right population. If you give them to many women, it might well be that outcome is poorer, as was shown in this beautiful publication. Corticosteroids started with more ligands, and it was serendipity. He was studying the onset of labor in lambs, in sheep, and gave these sheep corticosteroids. The lambs were born preterm, and surprise, surprise, they were more viable than they were supposed to be at the gestational age. And this is, as the characteristic is of a very intelligent person. He said, hey, they should be dead, these lambs, but look at them. And then he realized it might have been the effect of corticosteroids, and already 2 years later, he did, Ms. Hoey, the first randomized controlled trial on the use of corticosteroids, and showed they improved outcome if babies were indeed born preterm. By 1994, there were already 15 randomized controlled trials. By 2006, there were 21 randomized controlled trials, and that shows how stupid we are. Yes, sir. What did we do in these trials? We repeated exactly the same trial that ligands had been done in 1970, with the same dose and the same corticosteroids, etc., just to show indeed that he was right. If one of us would have been a little bit more intelligent, he would have halved the dose, or doubled the dose, or whatever it is. No, we just repeated exactly the same trial. And now, we are 30, 40 years later, we have no clue what is the best dose, and we might really give too much of the corticosteroid, but we don't know. He was intelligent. We were a disaster. Well, the only positive thing is that we now know, because of all these trials, that corticosteroids worked in the 1970s, in the 1980s, and in the 1990s. And that is important because nowadays neonatology has improved with surfactant, etc. And these data have nicely shown that also trials conducted in the 1990s showed a reduction in RDF, periventricular hemorrhage, and neonatal death. So yes, indeed, there is a case to give corticosteroids in women at risk of preterm delivery between 24 and 34 weeks. Betamethasone seems to be somewhat more effective than dexamethasone, but be aware of its effects on fetal heart rate variation and movements. Steroids probably also work when given earlier on 22-24 weeks of gestation, but these are observational cohort studies. Steroids initially were not used. Doctors were afraid to give them, and only the guidelines from the colleges came around in the end of the 80s saying, yes, please, you should give steroids in these women. So finally the doctors started, and that resulted in another disaster. Here we see a questionnaire in Europe in the year 2001, on 400 European centers. How often do you give corticosteroids? Well, in 40% of the centers, more than 3 courses will be given if the risk of preterm labor continued to be there. There was even one center where they gave 20 courses. So they must have started preconceptionally or continued after 42 weeks of gestation. I don't know. But this shows again the doctors. Patients want to be treated. Doctors want to treat. Yes, fortunately you didn't deliver last week, but still you have a short service or whatever it is. So let's give another course of these fantastic medicine, this corticosteroid. Thank you very much, doctor. You're the best doctor in town. Was there any evidence in 2000, when this study was conducted, that repeated corticosteroids helped? No. No evidence. In fact, only the first publication appeared in the early 2000s, and here you can see a Cochrane summary of repeated versus single corticosteroid doses. No effect on perinatal mortality, but a slightly improved effect on neonatal lung disease, severe lung disease, infant morbidity, etc. 20% reduction. At least that came from these first randomized controlled trials. Should they be given then to the whole group? Well, most studies showed that yes, they might reduce morbidity, but only in case of early preterm delivery. So you shouldn't give them again after 32 weeks, but only early. That came from 1, 2, 3. In fact, that came from all the studies. But in 2008, there was the publication of the Canadian study, a huge one, larger than all the other studies, and it showed no effect in the overall group. It showed no effect when given before 32 weeks of gestation. Here, the large series, this is the total population. If you look at stillbirth, neonatal deaths, severe RDS, etc., no differences at all. And here are the data from this beautiful Canadian study on infants delivered before 32 weeks of gestation. Steroids, placebo was 1 course of steroids, and the other was on average 3 courses, and you can see no difference at all. Do they have side effects? Fortunately, they studied that in these studies. Well, yes, birth weight is somewhat lower. Non-significant, yes, weight is significantly lower. Yes, in cases in which the pregnancy continued after 32 weeks, placental weight is lower following repeated courses. And also in the Crowder study, weight and head circumference were lower, and that was confirmed by the Canadian study. You can see that on average birth weight was 100 grams lower, length at birth 1 centimeter lower, and mean head circumference half a centimeter smaller. So side effects, yes. Outcome at the age of 2 years, according to the MAX trial, the Canadian, no difference. Outcome at 2 years, the Crowder trial, no difference. Outcome 2 years in the American trial, Wapner, no significant difference, but have a look. 1 cerebral palsy in the placebo group and 6 in the repeat group. That was not significant. However, it reminds us of the complication of steroids when given directly after birth in newborn infants. And in reality, 19 randomized controlled trials on early steroids in preterm neonates. Yes, for every 100 babies treated, 14 more were extubated by 7 days, 11 less have chronic lung disease, 7 less will die, 14 avoid late corticosteroid treatment. Hooray, hooray! But 6 more will have gastrointestinal bleeding or perforation, 12 will have cerebral palsy, and 14 abnormal neurological development and follow-up. The side effects seem to be larger than the positive effect. And it's in a way logical, because the fetal dose is about 0.1 milligram to the fetus per day for 2 days, whereas the neonatal dose is about 4 or 5 times higher, and usually given for a week or longer. But this shows very clearly that potent drugs have potent side effects. Corticosteroids poison with some positive side effects. And these are mice. And we gave corticosteroids 4 days before the birth of mice, on day 16. And you can see that there was immediately a significant increase in apoptosis here in the hippocampus. On day 16, on day 18, and on the day of birth, and here in another part of the hippocampus, exactly the same. You can see there was cell proliferation following steroids had stopped at all initially, and was significantly lowered directly thereafter. It is logical. Corticosteroids promote cell differentiation, but they reduce cell division, and that's why they're smaller than newborns at birth. Then apparently, directly after birth, there was an increased incidence of cell proliferation as if the body would make up for it, but when they were grown up, adults, in the hippocampus, you can see a significantly lower incidence of cell division. Here it is summarized in this scheme. Corticosteroids given on day 16, an increase in apoptosis for the first days, a decrease in cell proliferation, a compensation somewhat thereafter, but when they're adult, there is a reduced incidence of cell division. And here you can see the difference when they're grown up. And we need cell division in the hippocampus for learning and memory. And if you do this Morris water maze study, where the mouse has to find this hidden platform, yes, following corticosteroids, they need more time to find it, and they have to swim more for finding it. So there is indeed evidence of impaired learning and memory after dexamethasone treatment. This is the liver in these mice, and you can see central areas of fibrosis in the steroid group, and here you can see the heart in these mice with collagen indicating degeneration of meiosis replaced by fibrous tissue. And these mice on average died 30% earlier as compared to the control. So dexamethasone induces precocious aging and reduced lifespan in mice. Does that have implication for the humans? We are not mice, we don't have a tail. For the rest, there's not a lot of difference, but anyway. Well, these are the follow-up studies in humans. Thus far, completely reassuring, with the longest follow-up, which is from the New Zealand trial until the age of 30. No effect apart from some evidence of increased insulin resistance. Here is the hippocampus. Here, the control hippocampus, and there the hippocampus in which corticosteroids were given. But this is the human situation. You can see a lower density of neurons than the human. And these were 22 newborns born in my institute who died within the first 3 days after birth. By chance, half of them had been treated with steroids prenatally, and the other half not. And if you look at the density of neurons in the antenatal steroid group, it was significantly lower than in the other group. We have no clues. This was exactly the same as the mice. We have no clue if this will affect long-term outcome. But before we know, we have to study adults, probably at the age of 50, to see if it will be the same or not. Still, we have to be very cautious. This was again just to remind you that corticosteroids are very potent drugs. And potent drugs have serious side effects. The future might well be to combine corticosteroids with statins. And we recently did it in Redspur together with Dino Gisani in Cambridge. And if you give statins at the same time as corticosteroids, it seemed that we could prevent alterations in the cardiovascular system and brain development. But this should be now part of a prospective study in the humans. Should steroids be repeated? Well, I quote the Max study. Multiple courses of antenatal corticosteroids do not increase or decrease the risk of death or developmental difficulties by 5 years of age. Because there is no clear benefit, this approach is not recommended for routine use. Future research may be around for maybe specific situation where you might be able to repeat. Most importantly, the use of corticosteroids may well be reduced by better identification of women who really are at risk of preterm delivery. As we've heard before, cervical length measurements, if it's more than 3 centimeters, don't give steroids. If it's in between 1.45 and 3 centimeters, do vibronexin or another test. If it's negative, don't give steroids. You may also decide to determine lung maturation in case of a planned preterm birth of an IGR or otherwise fetus. At least we still do it, but I think we are more or less the only ones in the world. Spoken about IGR, there is no evidence from observational studies that corticosteroids improve outcome. Still, we all give corticosteroids in preterm delivery of IGR. So I think you should ask a young student in your department, how many of your patients who receive corticosteroids actually delivered preterm? In my hospital, it was 34%, just published in the American Journal. That's not very good, but it's not very bad either. There are hospitals where only 10% who got steroids actually delivered preterm. We should do much better in that field. Please be aware that corticosteroids reduce a temporary reduction in fetal heart rate variation of about 20 to 50%, 20 to 30%, induce a 50% reduction in body movement, whereas fetal breathing stops following steroids. We only found this 25 years after the introduction of steroids, and I wonder how many of our patients got a cesarean section because the doctor had given corticosteroids. Thereafter the patient said, I don't feel the baby moving anymore. So we did the biophysical profile testing. The biophysical profile score was only 4, so the doctor could say to the patient, I'm very glad I gave you corticosteroids because now we can take the baby out. I don't know how often it has happened, but I'm sure it has happened. This is not a deterioration of the condition of the baby. This is binding of the steroids to the brain stem, and this is exactly the same as the diurnal variation of fetal movements and heart rate variation, which is related to maternal cortisol levels. He was very intelligent. Sir Graham Liggins. I think we more or less, I think we more or less made a mess of it. And don't forget, women want to be treated, and doctors want to treat, but doctors should know better. Thank you very much for your attention.
Jerry, excellent presentation. Do we have some questions for Jerry? Yes. There, please. Yeah.
Jerry, I was always fascinated by